Well, good afternoon or good morning, wherever you are joining us. I am Dr. Jill Jim. I'm the Executive Director with the Navajo Department of Health and also a member of the Navajo Nation. I am of the Reed People Clan and born for the Red Streak Running into Water Clan, and I'm originally from Navajo Mountain, Utah. So I'm pleased to spend some time with you to discuss COVID today, and I will first provide an overview, then followed by some questions. So let's begin. As the news started to break about the COVID-19 pandemic, an alarm swept across American Indian and Alaska Native communities and leadership. Our collective memories of the 1918 influenza pandemic include memories of some of our communities experiencing 50 to 70 or to 90% mortality rates. The survivors, often children. Our communities were completely wiped out or left only orphaned children behind. Just recently, a report showed that many American Indian and Alaska Native children were left with no parents due to COVID-19 deaths. Once COVID began to spread, anxiety was fueled by scarcity of information, resources, PPE, testing, and personnel. Rapidly changing information on what the symptoms are, how the disease is spread, what the masking guidelines are, and who were at greatest risk for the disease. And many of these questions came from our tribal members. We knew we had additional challenges such as crowded homes with little capacity to isolate those infected, as well as multi-generational homes, raising potential of exposure of those in most danger of developing severe COVID-19. Not to mention, many in our communities do not have access to safe water and sanitation systems. This history and the current state of our systems and infrastructure, coupled with the fact that there were no treatments and no vaccines, led tribal governments to enact their sovereign rights to close our borders in efforts to keep the virus out of our communities until there were other tools to fight the spread and treat the disease. These conditions also led to early consultations with tribes and the federal government. As the world was facing the scarcity of PPE, testing materials and capacity, and contact tracing, the situation was dire in tribal communities. Tribes insisted on the right to have direct access to information, data, PPE, vaccines, and treatments. We all insisted on the right to self-determine our priority populations. We are still fighting to have direct access to information, particularly our information that we provide to federal agencies. Simultaneously, tribes looked within and enacted incident command centers. We mobilized to build capacity, such as stand-up alternative care sites, increase the number of negative pressure rooms, redesign clinic and hospital flow patterns, and mainly outdated and undersized facilities, set up screening units and develop methods to disinfect PPE as examples. Heartbreakingly, our fears were substantiated. Throughout the pandemic, tribal communities have shouldered the largest burden. Based on the most up-to-date data available from CDC, American Indians and Alaska Natives are 1.6 times more likely to be diagnosed with COVID, 3.1 times more likely to be hospitalized due to COVID-19 related condition, and 2.1 times more likely to die from a COVID-19 related cause. These troubling statistics highlight our tribal communities, how we continue to suffer disproportionately from this pandemic. However, the federal government has an opportunity to ease that distrust by providing directly the robust assistance and resources tribes need. A particular success, a demonstration that the federal government responded to tribal consultation, was the decision to create the IHS, or Sovereign Nation Allocation. This was a groundswell change, the benefits of which is indisputable, in stark contrast to the experience with H1N1 vaccine allocation and implementation in tribal communities and the resulting disparities. The Sovereign Nation Allocation shattered the inequities of the past. American Indians and Alaska Natives experienced early uptake of vaccinations and obtained for the first time the highest rate of vaccination compared to other populations. Tribes were able to maximize the efforts of the dedicated tribal public health and healthcare professionals and self-determined priority populations that would support vaccine confidence and protection of tribal culture keepers and providers. With this early work must be celebrated and recognized, much work remains. Conflicting or inconsistent messaging has done much to damage confidence in the information as well as confidence in vaccine treatment and efficacy. Historical trauma caused by federal policies also means that tribal communities continue to carry distrust of the federal government, which complicates efforts to reduce vaccine hesitancy. Tribal self-determination is key to combating this distrust and building confidence. That brings us to where we are now. Though we are all tired and wish through the pandemic was over, we are not yet there. So thank you, Dr. Fauci, for joining us today. We are hoping to understand where we are in the pandemic and what is on the horizon. So I'll start with my first question and then follow it by many others. And so my first question is, how concerned should we be about the BA.2 subvariant? And will there continue to be variants of interest and concern?
Well, thank you, Dr. Jim. Thank you for having me with you. It's a pleasure to be with you again. The BA.2 variant is a sublineage of the original Omicron. And we have found over the last couple of months that the BA.2 has overtaken the original BA.1 Omicron. It now is about 68% of all of the isolates in this country are BA.2. It has a transmission advantage over BA.1 in that it transmits more readily. And so when you have a virus that has a transmission advantage, within a reasonable period of time, it will become the dominant virus. It doesn't appear to be more severe in its consequences than BA.1, but it does transmit more. It should be noted that there is another sublineage variant called BA.1, BA.2.12.1. I know it gets confusing with all those numbers, but that is now about 30% of the variants. So it looks like as time goes by, this new 12.1 variant might actually outstrip BA.2. The sobering news is that each of the variants appears to be slightly, not profoundly, but slightly more transmissible than the previous one. So for example, BA.2 has been more transmissible than BA.1. BA.2.12.1 is more transmissible than BA.2. And in South Africa, they have a variant called BA.4, BA.5, which are more transmissible than the others. So we're going in the wrong direction for transmissibility, but fortunately, there does not appear to be a greater degree of severity with these new variants. So the bottom line to your question is, I'm always concerned about new variants, and that's the reason why we've got to do what you all have done very well in Indian country, and that is the level of your vaccinations is really quite good. And the best way to counter these variants is to get as much of your people vaccinated and boosted as you possibly can, as quickly as you can.
Yeah, and that leads me to the follow-up question of how should we prepare for future variants as a society? So not only in American Indian and Alaska Native communities, but as a nation.
Well, as a nation, in order to stay at least in tune with and hopefully ahead of the emergence of new variants, is to have a very efficient genomic sequencing surveillance system, which is much improved now than it was a year and a half ago, when we were only sequencing a relatively small proportion of the isolates as they emerge in the country. Right now, we're doing much, much better than we were a year and a year and a half ago. So the best way to prepare for these variants is to be aware of their occurrence, so that when you get something like a BA2 12.1, you know about it in real time, as opposed to retrospectively after the fact. So I believe that the surveillance genomic system is the best way to do that. That will also play into the upgrading, where appropriate, of variant-specific boosts if we need it. Right now, we're boosting with the ancestral strain vaccine. And fortunately for us, that boosting with the ancestral strain gives you pretty good protection against the subsequent variants, even though it isn't specific for the variant. But just in case, we are doing studies now, and we're looking at boosting with various combinations of variants, Delta, Beta, Omicron, to see as we go forward what the best regimen of boosting should be.
Yeah, thank you for that. And I think one thing that, as we are continuing to deal with cases every day and deaths still occur, I'm wondering how serious the long-term effects of long COVID syndrome is. And as an additional question to that, how serious the long-term effects are, but also what is NIH, the National Institute of Health, doing to study these effects and potential treatment of these symptoms?
Well, long COVID is a real and serious problem that we need to address. We're learning more and more about it, literally each week, each month. What we do know is that a range of 1% of people, and that varies from 5% to 30% or more, when they recover from the acute phase of SARS-CoV-2 infection or COVID, they have the persistence and the lingering of a constellation of signs and symptoms that are not readily explainable by an easily identifiable pathogenic process. In other words, there are symptoms that can't be explained by something that you can measure in a laboratory with a laboratory test. And that is such a symptomatology as severe fatigue upon normal exercise, where a person, for example, who was a good athlete and could exercise and move around, and all of a sudden they get completely exhausted when they do minimal amount of physical activity. The other is a variety of symptoms: muscle aches, temperature dysregulation, sleep disturbances, and something called brain fog, which means that for one reason or other, a person has difficulty concentrating or focusing, such as reading or looking at a computer screen. We don't know what the cause of that is. So what the NIH has done is that we're investing about $1.5 billion in studying large cohorts of people to determine what is the risk factor for developing long COVID, what is the underlying pathogenic mechanisms that we could possibly identify as the cause of long COVID. Are there any individual susceptibilities? Does it relate to whether you're vaccinated or not? For example, does a vaccinated person who have a breakthrough infection less likely to get long COVID than a person who's infected without having been vaccinated? And the data look like that's the case, that prior vaccination, even if you do get a breakthrough infection, is much less likely to give you long COVID. Once we find out, and I hope we will, what these pathogenic mechanisms are, then hopefully we'll be able to develop some therapeutic approach, whatever that might be. And to be quite honest, we don't know what that would be because we don't know what the underlying pathogenesis is. So we're collecting a lot of information by studying large cohorts of people before they develop long COVID, as well as people who have already developed long COVID.
Yeah, thanks for sharing that. I had an encounter with an individual not too long ago talking about how they were able to run 3 miles, and now they're starting to do only starting at 15 miles a day again. So it is very real, like you mentioned. So
Right.
thanks for sharing that. And then the next question is, we know that Pfizer is currently preparing to submit for an EUA, an emergency use authorization for its COVID-19 vaccine in children younger than 5 years old. When do you think Pfizer's COVID-19 vaccine will be approved for children younger than 5 years old?
You know, Dr. Jim, I can't give you a date on that because those are data that the FDA has, and I don't want to get ahead of the FDA and anticipate when they're going to do what they do very well. The one thing I can say for sure is that the FDA will act very expeditiously and will not delay a decision on the approval by emergency use of a vaccine in children once they get all of the data. And I think what people don't fully appreciate is that they can't make a decision unless they receive an application for an emergency use. And with the application, they get all of the data that's sufficient enough for them to make a determination, and that they have ample time to analyze that data. I hope that's going to be within a reasonable period of time, but I really can't accurately predict when that will be.
Okay, sounds good. And I know that this question has been asked of you several times during the pandemic, and I'm going to see where you're at with this, is that we have heard a lot about achieving herd immunity over the past year. And do you believe it's possible to achieve herd immunity for COVID-19?
I do not believe that it will be possible to achieve herd immunity in the classical sense. And let me explain what I mean by the classical sense. So herd immunity means you have enough protection in the community that the virus has no place to go. We have achieved herd immunity with measles, which is a really good example. We haven't eradicated measles. There's measles all over the world, but there's enough critical number of people who are vaccinated and protected that there is no real chance of the virus spreading in the community. That is possible because of a couple of reasons. And those reasons are different with COVID. And that will give you an explanation of why I do not believe in the classical sense that we will achieve herd immunity. First of all, measles is a very constant virus. It does not change. The measles that we had 10, 15, 20 years ago is the measles we have today. Point number one. Point number two is that the durability of protection against infection after you've been infected and recovered, or as is usually the case today, after you've been vaccinated, the durability of that protection is usually lifelong or close to lifelong. So you have a virus that doesn't change, and you have protection that's lifelong, and you have a very effective vaccination program. That's not the case with COVID. Why? SARS-CoV-2 has already shown us that it continues to evolve with multiple variants. We've seen multiple waves with different variants, so it's not a constant virus. Number two, by the very nature of our response to coronaviruses, the durability of protection following either natural infection and recovery and or vaccination with or without boost is not very durable. It is by no means lifelong, and often immunity wanes after a few months. We've learned that through experience. So when you have a virus that changes over a period of time with multiple variants, and immunity, which is not very durable, it makes it very difficult to achieve, as we've said, herd immunity in the classical sense.
And I guess that brings me back to sort of, you mentioned with the measles and having a vaccination program. Do you think we're headed towards that direction with the COVID vaccine, sort of standardizing that and going forward?
You know, I believe that what we likely will see, given the fact that we continue to have the evolution of variants, I can't say for sure, but I would not be surprised if we had a situation where we would have to vaccinate people literally on a yearly basis, or at least intermittently. May not be every year, but I think at least more than just a one-off where you vaccinate people and then you're done. I don't think that's going to happen for the reasons that I just gave, that we have the emergence of variants and the durability of the protection is not very long. We know that from the common cold coronaviruses, where we continually, year after year, get infected with the same virus. We have 4 common cold coronaviruses, and each of us, you and I included, have likely been infected with common cold coronaviruses multiple times in our life.
So you think it's possible to annihilate COVID-19, or will we be living with it for years to come?
Well, we've only eradicated one virus that's a human virus in all history, and that is smallpox. And we did that for the reasons that I mentioned. It doesn't change. It's a stable virus. The body makes a very good immune response that's lifelong. And we've mounted a global vaccination campaign. So we're not going to eradicate SARS-CoV-2. Are we going to eliminate it? I don't think we're going to eliminate it from this country, again, for the reasons that I mentioned. It's a changing virus. The durability of immunity is low, and we don't have a universally accepted vaccination program. There are many people in this country who refuse to get vaccinated. So what I think we will have is a level of what I call control, namely a low enough level of virus circulation in the community where people will be getting infected, but it will be at a level that there will not be very many hospitalizations, both because of the vaccination, but also because of drugs that we have, like Paxlovid, that can keep people out of the hospital, and that it won't disrupt our society the way COVID has over the past 2 years. Economically, from an entertainment, casual, leisurely standpoint, in the schools and employment, I don't think we're going to see that kind of disruption, even though the virus will still be with us, I think, for a foreseeable period of time.
Yeah, that's well understood. And then, as you mentioned, I think when we're talking about the unvaccinated, I'm wondering what your advice would be today for those that are still unvaccinated. What would you say to them?
Well, I would almost plead with them to get vaccinated for the following reason. If you look at the statistics of the deaths and hospitalizations in vaccinated versus unvaccinated people, the differences are profoundly obvious. It's the overwhelmingly the people who are hospitalized and the people who die are among the unvaccinated. Vaccinated people get infected because the vaccine does not work that well against protecting against infection, but it works very well in protecting you against getting severe disease. So I would encourage the unvaccinated, for their own safety, for that of their family, as well as for that of the community response, to get vaccinated. And if you are vaccinated, then make sure when your time comes up and you're eligible to get boosted, that you get boosted. It really doesn't make any sense when you have a vaccine that is life-saving, that has saved literally tens of millions of lives worldwide, that for reasons that are still difficult to understand that people don't want to get vaccinated.
Well, I appreciate that advice for the unvaccinated individuals and those loved ones that can hear that message as well. And one thing that we started out with was with vaccinations. I know that the vaccination rates that you learned were really high in American Indian and Alaska Native communities. Is there anything that surprised you while you were working with tribes over the last 2 years?
Well, I wouldn't say it was a surprise because I've had experience with Native Americans, Alaskan Indians, and others over the years. And one of the very positive aspects about the tribal nations is the degree of communal spirit and the idea of taking care of each other and sticking together and listening to the wise advice of your elders and your community leaders. And I wasn't surprised, but I was very, very gratified to see that the vaccine uptake in Indian country was very, very high. In fact, the vaccinated rate among the Alaskan Natives and American Indians was really greater than any other racial or ethnic group. When you compare racial and ethnic groups, Indian country did better than most any other minority groups with vaccines. So my feeling would be that we should use the example of what you've been able to accomplish when we talk about the need to get high rates of vaccination in other minority groups, because you've done that very, very well. And I think, as I mentioned, it's really a testimony towards the spirit that you have among your nation, that you care for each other, you have respect for appropriate authority, such as your elders and your community leaders. That sets a good example, I believe, for others in this country.
Yeah, thank you for that and sharing that. It's very important. And as we sort of wind down, I wanted to just kind of share, just as you have and I have been here, given the authority to respond to the pandemic for the Navajo Nation. And I think it's been difficult. And I think I always indicate that I'm not in the really of the recovery or post-pandemic, because we're still in it. So I'm wondering how you have dealt with the pandemic. What have you learned about yourself throughout this public health crisis? And I just wanted to see what your perspective is. And I learned a lot about myself and through the hardships and dealing with this. I just wanted to see if you could share some of your methods or your strategies, or what did you learn about you as a person?
Well, this may not be readily applicable to anyone else because of the unusual position that I was in as the leader of the effort, as the director of the Institute, and as the chief medical advisor to the President of the United States. Well, what I learned about myself is what I learned about our country, is that how resilient we are, and how even when faced with an extraordinary challenge of a potentially and in reality deadly outbreak, how we've been able to pull together through this. My one big disappointment in all of this was the degree of divisiveness that we've seen in our country, where instead of pulling together as a nation to fight the common enemy, which is the virus, we saw too often divisiveness based on political ideology, which really, in my mind, has no place when you're trying to fight the war against a deadly outbreak. You succeed in a war when you galvanize all your forces against the common enemy. And what we've seen, unfortunately, in this country is a degree of divisiveness which has not allowed us to as effectively respond as we could have, because of misinformation and disinformation, particularly around the area of vaccines and wearing of masks and doing the things you need to do to avoid infection. There's been so much distortion of reality and misinformation that I think that that has been a negative and a hindrance to a successful effort. So hopefully we'll learn a lesson that we've all got to pull together and not be at odds with each other.
That sounds good. So any other, I know we kind of talked about how we don't really, well, I don't really see COVID going away too, but is there any projections that are either short-term or long-term, and, or is this it? Is this it? And we will continue to live and coexist with COVID.
We will live with it, but I hope we live with it at such a very low level that it doesn't disrupt us the way it has over the last 2.5 years, where it doesn't disrupt the normal activities of society. As I mentioned a few times during this discussion, we're not going to eradicate it and we're not going to eliminate it completely, but hopefully we'll keep it contained at a low enough level that it doesn't have a major impact on us.
And one last question, what would you like to say to the 574 plus tribes that are federally recognized that you haven't already said today?
Well, I've said a lot, but I want to just say how much I respect and admire of what you've done, because as you said, you have health disparities, probably because of the social determinants of health, but you've held together and you've done a very, very good job of getting your communities vaccinated. So my final word to you is that I have a great deal of respect for you and I congratulate you on a job well done.
Thank you, Dr. Fauci, and I'm also grateful to consider you a colleague in the field that we're in. And I just want to thank you one more time for your time with us today. And in Indian country, I'm sure that many people will learn and will appreciate all your comments today. And I just want to say Ekehe and Hagone, and that means thank you and have a good day.
Thank you very much, Dr. Jim. It's good to be with you.